The following podcast is part of a certified educational activity titled Mission Possible in Prostate Cancer, Leveraging Genomics, Modern Therapeutics, and Individualized Patient Care. Access the entire activity and complete the post-test at peerview.com/TRR860. Downloadable slides and practice aids are also available.
Good evening, everybody. Please keep having your dinner. That's totally fine. I'm Karim Fizazi from France, medical oncologist doing GU Oncology. I'm delighted to welcome you for this session. We called it Mission Possible in Prostate Cancer. Leverage genomics, modern therapies, and individualized patient care. And I really like the final part of this title because we are actually aiming towards individualized care for all patients with prostate cancer, which is just great. So tonight I'm being joined by Professor Elena Castro from Madrid, Spain, and by Professor Matthew Smith from Boston, the United States of America. So today all our goals are triple. Number one, we would like to explain basically where the biology stands. Don't be afraid. We're going to do our best to make it easy, but really to try to explain what is the rationale for developing trials that you're seeing in congresses and as publication. Then we will try our best to show you the main efficacy data from the various trials we saw in the last years. And finally, we will try also to provide guidance to help you better manage side effects patients may develop, and most importantly, mitigate those side effects. So first, we will speak about metastatic prostate cancer. And I'd like to remember you that, of course, we all know that, for example, here in the US, most men who are diagnosed with prostate cancer are diagnosed with localized disease, probably 90-95% of the total, while only 5 or 10% of those patients are diagnosed with de novo metastatic disease. But if you look at patients dying from prostate cancer, it's a totally different story. And actually, it's really half-half between those two scenarios, with approximately half of the death being represented by patients with de novo metastatic disease, while the other half is indeed represented by men who initially were diagnosed with localized disease and then things didn't turn well. So this emphasizes that if you really want to beat this disease, either we need to invent better treatment for metastatic disease, or of course we need to diagnose the disease before it becomes metastatic. But I think that is very important to remember. Also, and more globally speaking, de novo metastatic disease is actually the big problem of prostate cancer. And I'm saying that because, again, as I said before, the incidence here in the US is 5 to 10% amongst patients who are diagnosed with the disease. In Europe, depending on the country, pretty much the same thing, 5 to 30%. But if you go to other countries, and on purpose I emphasize two big countries in terms of populations, India and China, approximately 60 to 70% of patients who are diagnosed with prostate cancer in those countries actually have metastasis from the very beginning. So globally speaking, again, metastatic disease is the big problem, much more than localized disease. We will have to speak about various treatments, various strategies, and it's obviously super important that we understand that shared decision-making should be part of our practice. We should provide time to all our patients, explain what the options are, what are the pros and cons, the most honest we can. And to do that, you may also have a look at ZERO, which has some documents helping better develop shared decision-making. And with this, I'd like to invite Professor Smith to explain how and how important it is to use treatment intensification in men with metastatic castration-sensitive disease. Matthew, please.
Thank you. Good evening. That was a beautiful introduction to my talk on metastatic prostate cancer and the role of treatment intensification. Metastatic prostate cancer is treatable but not curable, with very few exceptions. And survival is related to the anatomic sites and extent of metastatic disease and the manner of presentation. So you can see the different survival curves shown on the right panel here, with patients with de novo high volume metastatic disease having a median overall, 5-year overall survival of less than 50%. Patients who present with recurrent low volume metastatic disease conversely have about an 80% 5-year survival. So very different survivals depending on the extent of disease and the manner of presentation. And a lot of that is really driven by biology, just not opportunity of when you find the disease, as we'll talk about. And those survivals were with ADT alone. There's been really extraordinary progress in the field showing the role of treatment intensification as initial therapy for patients with metastatic prostate cancer. There's sort of a timeline of the various trials showing improvements in progression-free and overall survival. Several studies looked at addition of docetaxel to ADT, reported it in about 2015, charted STAMPEDE Arm C, and missing here importantly is GETOG 15, I think is led by my colleague to my left. Also led by my colleague to my left, abiraterone study showing in about 2017-18, showing improvement in overall survival by addition of abiraterone to ADT, the Latitude trial. Similar observations in STAMPEDE Arm G. Other ARPIs have shown improvements in overall survival as doublet therapy compared to ADT alone, enzalutamide, apalutamide shown there, and I'll talk about those trials. And then more recently, there's been studies of so-called triplet therapy, piece 1 looking at abiraterone and docetaxel plus ADT, and ARASENS looking at darolutamide, docetaxel, and ADT. And then we'll talk more recently about the doublet study, ARANOTE, looking at the addition of darolutamide to ADT. So really extraordinary body of work with consistent demonstrated improvements in progression-free and overall survival. And we do see over time an increasing use of treatment intensification. You can see in the sort of dark blue bar, starting in 2017, about 3/4 of patients with metastatic prostate cancer received ADT alone. That's decreased to about 35% as of 2023, but you still see that substantial proportion of patients receiving ADT alone, despite consistent high-level evidence for improved overall survival by treatment intensification. I'm not suggesting for a minute that the right proportion is 0, because there are going to be patients where treatment intensification may not be appropriate, but I would submit that 35% remains sort of much too high based on this remarkable body of evidence showing improvements in progression-free and overall survival. So let me briefly go through the evidence. This will serve as a review. So shown here are the charted and STAMPEDE studies looking at the addition of docetaxel to androgen deprivation therapy, in both cases showing a significant improvement in overall survival by addition of docetaxel compared to ADT alone, with hazard ratios of between 0.72 and 0.81. And this really was critically important in setting the stage as this important disease state as a testing ground for additional studies that followed, and some of those I summarized on that timeline. So in that period of time, the addition of docetaxel to ADT became a new standard of care, and this was quickly followed by other studies that looked at other drugs, the ARPIs. Titan looked at apalutamide, Arches looked at enzalutamide, and the first of the group, Latitude, looked at the addition of abiraterone and prednisone to ADT. What's remarkable here is the consistency of observations across these studies. I mean, you think about this, studies done with largely partially overlapping timelines, 3 different drugs, very different geography, different eligibility criteria, and the hazard ratios are either 0.65 or 0.66 for overall survival. This is about as consistent an effect as you could possibly imagine, and I would submit really compelling, right? This is a large treatment effect by addition of an ARPI early, and this effect was seen despite a very high rate of crossover to subsequent treatment with an ARPI. And that's something to think about when we talk about other studies done later with other agents where that argument, the crossover to subsequent life-prolonging therapy is an explanation for why no survival benefit may be seen. But in this case, consistently in these trials, we see this big survival benefits despite a high rate of crossover. And some of the trials, in fact, encouraged the crossover partly to facilitate enrollment. So what did we learn by these initial studies in mHSPC or mCRPC? Well, really, the addition of either docetaxel or an ARPI improved progression-free and overall survival. And then quality of life was maintained or even improved with the ADT-ARPI doublets. Really wasn't known which is better, ARPI or docetaxel. I mean, I think clinicians and patients have largely voted with their choices, right? ARPIs for most patients are going to be easier to accept than docetaxel chemotherapy. There's never been a direct head-to-head trial comparing these agents in this setting, although the STAMPEDE experience did provide the opportunity to do a contemporaneous comparison of patients who were enrolled at the same time to different arms of the trial. So it's not a direct randomization, but a contemporaneous comparison. And when that was done, there was no difference in overall survival between ADT docetaxel versus ADT abiraterone doublet. However, other time-dependent variables, intermediate endpoints, including progression-free survival, time to symptomatic progression, favored abiraterone compared to docetaxel. Whether that actually represents greater treatment efficacy or simply the fact that abiraterone is given continuously, so you're going to see an effect on that intermediate endpoint versus the 6 cycles of docetaxel done up front, remains to be determined. This, of course, led to the next logical question. Well, if either an ARPI or docetaxel improved survival, what about triplet therapy? And Professor Fazazi led piece 1 looking at this question. Piece 1 was a 2x2 factorial design, and Karim, please correct me if I say anything wrong. I reviewed it for today, because I knew you were here. About 1,000 patients randomized in piece 1, 2x2 factorial design, standard of care plus minus abiraterone. The other part was prostate radiation therapy. Originally, standard of care was included docetaxel at physician choice, and then about midway through the trial, based on the results of CHARTED and STAMPEDE, docetaxel was made mandatory. And so the triplet question was asked in the subgroup of patients in the trial, about 355, who received ADT and docetaxel as standard of care. And what I'm showing here is the PFS outcome in that subgroup. So you can see there's a very clear separation of the curves favoring the triplet ADT, docetaxel, and abiraterone versus ADT and docetaxel. This was also borne out with overall survival. I believe the hazard ratio is about 0.81 or 0.82 for overall survival. Really, so it's, again, establishing triplet therapy as superior to ADT docetaxel doublet. Prostate radiation therapy was also assessed in this trial as a sort of independent question in the 2x2 factorial design. There was no overall survival benefit for prostate radiation therapy. Although you can see on the right-hand panel there was a clear benefit in favor of reduction in risk of serious GU events. Kind of stands to reason, right? If you treat the primary tumor, you prevent events mostly attributable to disease progression in the prostate or pelvis. ARASENS was a trial that looked at triplet therapy with ADT, docetaxel, and darolutamide. This was I'd say, I guess, a more straightforward study design, 2 arms. Everybody received ADT and docetaxel. and then you're randomized to darolutamide or placebo with the primary endpoint of overall survival. And here you see, a clear effect favoring triplet therapy compared to ADT and docetaxel. Hazard ratio is 0.68 for overall survival, highly statistically significant, as you would expect. And the results of this trial led to FDA approval of darolutamide and mHSPC in August of 2022. There have been a lot of interest in subgroup analyses from this trial, and I guess fair to say there's been sort of consistent benefit across pretty much any of the subgroups analyzed. Shown on the left-hand panel are older versus younger patients, significant improvements in patients less than 75 as well as those greater than 75. For what it's worth, the point estimate for the older patients is actually somewhat better than for the younger patients, so I would speculate that difference is not statistically significant. GCFS use was used prophylactically at physician discretion, and the addition of darolutamide did not increase either GCFS use or docetaxel dose modification, so really I think kind of eliminates any concerns about potential drug-drug interactions between darolutamide and docetaxel. Now, when we designed ARASENS, it was at the time that CHARTED and STAMPEDE had first demonstrated that docetaxel improves overall survival. And before, Kareem's LATITUDE study reported that ARPIs improve survival. So we were left with this open question of what the right control group would be, and we elected ADT docetaxel at the time. Historically, people look back and say, why did you do that? No one likes to give docetaxel. Why did you do that? Well, at the time, it was the right thing to do because there had been overall survival benefits shown in 2 trials. So we chose the winning arm of the previous trials as the control group. That left the question then, though, of, well, can you give darolutamide without the docetaxel? And this led to sort of the pragmatic study design of the phase 3 ARANOTE study that looked at that question. And to no one's surprise, you improve the primary outcome of the study, in this case, radiographic progression-free survival. The study was not primarily designed to address overall survival. It was, again, a pragmatic study to look at this question of doublet therapy with ADT and darolutamide. ARANOTE efficacy improved outcomes across a variety of subgroups, much as was seen with the other lutamides, as well as with abiraterone. This benefit is seen for both patients with high volume and low volume disease. As you can see, like these curves separate very early and remain separated. So in a lot of ways, I think the CHARTED study did the field an unintentional disservice by the early narrative being that docetaxel improved survival only in patients with high volume disease. So I think many clinicians got fixed in their mind the idea that intensification was only for patients with high volume or high burden metastatic disease. In the case of ARPIs, this is unequivocally not true. And this is shown here with ARANOTE. The same observation have been made with progression-free and overall survival in really all of the other studies of ARPIs as well. And some of that, so this is some other questions that have been raised, and really are the benefits of treatment intensification consistent for patients across risks for other medical comorbidities? So this is a post hoc analysis of TITAN, of apalutamide in patients with mHSPC, looking at patients with a history of cardiovascular disease, metabolic risk factors, those who had those risk factors and required concomitant medications, and those who had no cardiovascular or metabolic risk factors. And what you see is sort of a consistent benefit across all of the subgroups, sort of making the argument that treatment intensification, it really is a relevant consideration for the vast majority of our patients, including those with other meaningful medical comorbidities. Libertas looked at depth of PSA response in early participants with apalutamide, looking at who are receiving continuous versus intermittent ADT for mHSPC. We love PSA data, and of course the PSA data for initial treatment of metastatic disease is particularly beautiful. My colleague Eric Small termed these like pelican plots with the sort of mouth wide open of like this, massive separation of the curve when you look at these. Now, while I've tried to make the strong case for treatment intensification, it is worth noting that the drugs that we've been discussing have potential side effects. The ARPIs, those include hypertension, edema, LFT abnormalities, hypokalemia, fatigue. There are pill burdens. Some of these drugs may exacerbate the commonly reported adverse events of androgen deprivation therapy. There are considerations about cardiovascular disease, cognitive and bone health. Chemotherapy with docetaxel has its own additional side effects, including neutropenia, neuropathy, and worsening fatigue. And so these are things that we really do need to consider in our patients and individualize our treatment choices. I'll go back to that number I mentioned earlier. About a third of patients in the United States continue to receive ADT alone as initial therapy for metastatic disease. I think that number is too high. Again, the correct number is probably not zero, because there are still going to be patients who may not be good candidates for treatment intensification, either due to really a combination of particular older age, significant comorbidities, and I would also submit milder disease. Our goal is to prevent disease-related morbidity, and if the patient in front of you is very likely to die of unrelated causes before they progress with their prostate cancer, either ADT alone may be appropriate, or in some cases observation without ADT for those with the smallest burden of disease. And maybe it'll come up in our discussion, but sort of PSMA PET scans have dialed this all up too, right? So we recharacterize many patients with previously called PSA-only disease, we now call, PET-positive disease, so we can now find their metastatic disease. So they have the ultimate in low-volume disease. Biochemical recurrence is very common in patients who've received prior treatment. This explains Kareem's earlier observation that about half of the deaths from prostate cancer are those who were originally diagnosed with localized disease. How do they get into trouble? Well, their PSA rises and they're diagnosed with metastatic disease later. The EMBARK study looked at this important patient population, really looking at the question of treatment intensification there. Patients in EMBARK, 3 arms of the trial, leuprolide acetate as the standard of care, enzalutamide plus leuprolide, or enzalutamide monotherapy. And as you all know, the enzalutamide arms outperformed the standard of care arm, and that led to expanded regulatory approval of enzalutamide in 2023. Lots of interesting questions raised by this study, including, role of intermittent therapy. Is enzalutamide monotherapy really the way to go? And then the other critically important question is, does this patient population truly exist anymore, meaning non-metastatic prostate cancer, because PSMA PET scans would reclassify many of these patients as metastatic disease. ARISTEP is kind of looking at this, in a way, the next generation question. So this is darolutamide and ADT in what is being called high-risk biochemically recurrent prostate cancer. These are patients who have negative conventional imaging, but positive PSMA PET scans. So in many ways, it's like a subgroup of the patients who were studied in EMBARK, but it'll be the ones who had positive PSMA PET scans. So that'll be interesting sort of way to think about how we use imaging and how we manage this very common disease state. So there's a general awareness that PSA doubling times are a strong predictor of outcomes in patients really across a wide range of disease states in prostate cancer, including those with biochemical recurrence after prior definitive local treatment. And it was part of the EMBARK study, and that really followed data analyses that were done earlier in patients with castration-resistant disease. There's a number of studies moving treatment intensification even earlier. We already have data from STAMPEDE looking at patients with very high risk and regional risk prostate cancer, showing a benefit for adding abiraterone acetate to ADT and radiation therapy. These studies are looking at similar questions. Proteus will look at apalutamide ADT versus placebo and ADT in the perioperative period for patients undergoing radical prostatectomy for high-risk localized disease. Atlas, DASL-HiCaP, and PEACE-2 will look at systemic treatment intensification for patients receiving ADT and radiation therapy as standard of care for high-risk disease. So this is the design of the Proteus study again. ADT apalutamide versus ADT placebo prior to surgery, and then in a sort of a maintenance after that for a total of 1 year. A really interesting study, kind of established the potential role of systemic therapy with surgery, as well as addressing the question of treatment intensification. And so, sort of as I reach the end of my presentation, I want to remind all of you to consider what you've already heard about, which is ZERO Prostate Cancer. This is a very important resource both for clinicians and patients. Shared decision making, as you heard about, is critically important. We all have limited time in our practices. This is an easy way where you can refer patients to resources, help them ask the best questions, learn on their own, and really help them get the best possible care. So I'd encourage you to look at that. And I'm going to end with a case. I'll present the case, and then Kareem will take over the discussion part of this. So this is a 57-year-old patient who had a screening PSA of 30 nanograms per ml. Prostate biopsies reported extensive Gleason 5+4, 4+5, and 4+4. Prostate MRI reported a confluent PIRADS 5 lesion throughout the left peripheral zone, extending from the apex to the base, with a possible metastasis to the right iliac bone. And then PSMA PET CT showed 6 bone metastases throughout his skeleton, a couple of which are shown there. If you can't see them, look for those yellow arrows. That'll tell you where they are. And to Kareem.
Thank you, Matthew. I think this is really interesting case because first, it really shows that conventional imaging is just misleading. By CT scan/burn scan, this would be classified as an oligometastatic gentleman or low volume, if you will, and out of a sudden you figure out that he has at least 6 bone metastases, and maybe more, because PSMA PET probably doesn't see everything. So I think this really challenge whether we should keep using low volume, high volume classification. Of course, counting the metastases has an impact on prognosis. We all know that, and that's not new, and that's not specific to prostate cancer. But really, whether it's truly helping us for decision making, I really wonder, especially when it comes to de novo metastatic disease. When it's a relapse, of course, most patients with relapse would develop oligometastatic relapses, so it's probably a bit different. But in this case, would you typically discuss 2 drugs, 3 drugs? Would you irradiate the primary? How would you handle this gentleman, and what would be the conversation typically? Either yourself, Matthew, Elena, who wants to start first?
Well, I think 2 drugs for sure. Mm-hmm. So ADT perhaps shouldn't be the standard of care anymore. There will be some patients that benefit from ADT alone, but in the majority of our patients, we should intensify treatment with an ARP. Then the question is whether this patient will benefit from chemotherapy or not. And for when we only have evidence of disease in the PSMA PET, the studies have been conducted with conventional imaging. We don't have a direct comparison between triplet and doublet. And this is something that needs to be discussed with the patient because it's a young patient in which we are seeing that there's dissemination of the disease beyond the prostate. So perhaps the discussion is this patient may need chemotherapy, if not now, at some point during the course of the disease. So I don't have a clear answer for this case, but definitely something that needs to be discussed with him. I don't know.
Yeah, and I sort of chose this case because there isn't a clear answer, right?
Yeah.
So like, if it was easy, it would be easy. So, but I think I agree with what you said, like young guy. The other point is a big primary tumor. Mm-hmm. So that like influenced my thinking a lot. So this is, so certainly 2 drugs, ADT, ARPI. We chose to give him docetaxel as well. We also radiated his primary, right? So we usually think of like high volume disease as the best candidates for 3 drugs, and low volume of the disease, the best candidates for prostate radiation. This is kind of the maybe unusual patient where I think all of the above makes sense. The other thing we commonly do now will be to look at his tumor genetics to see if there are other like adverse features that would predict a worse outcome. And as we're going to learn at ASCO, this ASCO, about the role of predictive biomarkers for those who are more likely to benefit from either docetaxel or an ARPI. So that I think is going to be I think that's sort of the next wave of like information and sort of adopting that in our routine clinical practices. But when we've already been doing some of that, but I think after this meeting I'm going to be more compelled to do that when we're on the fence about who should be receiving chemotherapy.
I would agree. Actually, I would probably have, more than probably, I would have made the same decision as you made. We actually in piece one, we really used 3 drugs plus radiation therapy, of course in one of the randomization arm. So it's totally doable to do so using the radiation therapy when you're done with the docetaxel. And actually the benefit we saw from the radiation is pretty much the same in patients with low volume and high volume. And it's mostly about preventing the local progression, of course, with the effect you showed on the slide, Matthew. There was a question about what is the ideal profile between doublet and triplet. I think we did all our best to address that. But there was another question, which is, when do you expect the results for the new adjuvant and adjuvant trials, Proteus, Atlas, etc.? Are they maturing soon?
I'd say soon. I don't know. I don't have the exact timelines, and if I did, I couldn't tell you anyways. But I couldn't publicly disclose that. But I'd say in the next few years, we're going to be seeing probably results from all of those trials that I saw that I showed on that table.
Yeah. Right. Yeah, and they have whole complete the accrual and quite a long time ago. So events are coming. All right. For the sake of time, let me move to the next presentation, which is about just what we were speaking about, the next steps for patients with metastatic hormone-sensitive disease, and also options when progression occurs. And I will be helped by Elena in our talk about the second part of the talk. So what next? Probably we are waiting very, very soon for 3 pieces of data using the targets that are already validated or at least tested in patients with castration-resistant disease. And we do have trials addressing the same questions now in castration-sensitive disease. And I'm speaking about PSMA targeting, also PARP inhibitors in patients with DNA repair defects, and finally AKT inhibition in patients with PTEN loss. And all this is maturing very rapidly. We will see in the coming days the first trial using a PARP, and I think we will see also very soon other trials for AKT targeting, and maybe in a year's time PSMA targeting. So let's see how it goes and whether we need to actually change what we just spoke about regarding doublets, triplets. It might be actually quadruplets or different triplets, etc. Let's see. So just for you to better understand what we're doing from a biological standpoint, and don't pay too much attention to this complex slide. I'll try my best to explain it in easy words. It's already late tonight at ASCO. So basically, you have 2 pathways in parallel. One is the androgen receptor pathway. The other one is the AKT-PTEN PI3 kinase pathway. In approximately 20% of all the patients with metastatic disease, PTEN is lost. In these patients, the PI3 kinase pathway is activated, and every time you will target, say, the androgen pathway, you will activate the other pathway, and vice versa. So if this is true, and this is what the lab is telling us, in these patients, we should target both pathways in parallel, so both AKT inhibition and AR targeting, okay? So this is really the rationale for developing AKT inhibition with, say, abiraterone, for example, but it could be also an AR inhibitor. So to do this, we're waiting for data from the Capitello 281 trial, which is a large phase 3 trial where 1,000 men were randomized. All of them had de novo metastatic disease, and all of them had a PTEN deficiency as determined by immunohistochemistry with a central testing. They were randomized on a 1-to-1 fashion to receive abiraterone alone plus ADT, of course, so doublet, or the same plus capivasertib, which is an AKT inhibitor. We saw a press release approximately 6 months ago telling us that the trial is positive by its primary endpoint of radiographic progression-free survival, so we should see the data probably soon. Regarding lutetium PSMA, and I think we'll speak about lutetium PSMA in castration-resistant disease, so of course it made all sense to test the same approach in patients with castration-sensitive disease. The PSMA addition phase 3 trial has also completed its accrual, same large 1,000 plus patients trial, and again randomizing a doublet plus or minus lutetium PSMA. So probably data, say, next year. There's also another phase 3 trial called PSMA-DC, which is looking at lutetium PSMA versus observation in patients with oligometastatic disease this time. What about academic trials? In Europe, we have the ongoing P6 program, and this is a platform of phase 3 trials for patients with metastatic hormone-sensitive disease. So we are actually addressing different questions in different subgroups of these patients, defined either clinically or by imaging or by the biology. So for example, we have for patients with oligometastatic disease, the P6 oligo trial, which actually has completed its accrual, looking at whether we should irradiate with SBRT the oligometastasis deposits. And this was completed probably 6 months ago now with 500 plus men randomized. We also have a second trial addressing the question that nobody addressed until now, I think, which is that of vulnerable patients. Typically the old grandpa with many diseases, quite hard to treat, nobody does what to do. Matthew was referring about ADT alone, remaining probably the standard of care for some of these men. And this is why we are randomizing whether we can intensify these patients with darolutamide, understanding that darolutamide is typically very well tolerated. So, and this is actually occurring. When we started, I really didn't know whether we could make the accrual viable, but it's occurring very nicely as planned. We also have 2 trials, which I think are more innovative, looking at whether we should further intensify or de-escalate treatment according to the PSA value at 6 months after the onset of therapy. So the good responders and the poor responders. The poor responder trial is currently ongoing, and we are randomizing whether we should add lutetium PSMA in these patients with still detectable PSAs after 6 months of therapy using whatever you like, doublet, triplet, plus or minus the radiation. This is currently ongoing, and the good responder trial is supposed to start probably in June, so very soon, and this will try to limit the duration of therapy with just stopping the 2 agents when it's a doublet. So I think those questions are very important and will be informative to all the patients. Coming back to pharma-supported trials, we have, as I said before, PARP inhibitor trials. For example, amplitude using niraparib plus abiraterone versus abiraterone alone will be reported in 2 or 3 days from now, Tuesday morning, so please stay until the end of ASCO. I think this is an important trial. And this is, of course, only, actually not of course, for patients who are selected based on molecular grounds with DNA repair defects. TALAPRO-3 is asking pretty much the same question, but this time with talazoparib and enzalutamide. It has also completed its accrual, and it should read out probably, well, I should not say when, but sometimes. We actually have also a third trial, which is the EVOPARP trial, looking at a next generation PARP inhibitor called saruparib. And this trial is, I think, currently ongoing in terms of accrual, so stay tuned. But it will be also interesting to see whether next generation PARP inhibitor can be better tolerated as compared to the current generation. So let's come back to Matthew's case. So this patient, let's say, was, as he told us, treated with a triplet regimen using docetaxel, ADT, and darolutamide. 18 months later, his PSA, which actually fell down to, say, 0.3 or something like this, is now starting to rise. 0.8 first, then 1.2 nanogram per ml, over 6 months. First thing to do, by the way, is double check the testosterone level to make sure the patient is castrated, and in this case, he is castrated, meaning that he's developing, unfortunately, early castration-resistant disease. Asking the patient how he feels, he now reports mild symptoms with, some back pain, not strong, sometimes taking a pill or two of paracetamol. And the imaging using a burn scan and a CT scan indeed shows that there are new lesions appearing. We'll come back to this case in a second. But let me remind you data that are actually already quite old, about 10 years ago, about radium-223 in these men with castration-resistant disease and mostly bone-predominant disease. This trial actually was the first phase 3 trial looking at the efficacy of radium-223 in these men, and it showed for the first time that radium-223 is associated with approximately a 30% reduction in the risk of death. And this was true in the two subgroups of the trial, those who had already received docetaxel chemotherapy, which was the main drug at this time, and actually this was the majority, but also in those who had not received docetaxel because they were simply considered to be unfit for docetaxel. So this clearly is an option for both populations. Then during the development of radium, it was tempting to combine radium-223 with the new appealing drugs, which were the AR pathway inhibitors, including, for example, abiraterone. So this trial, AR-223, was led by Matthew, and it's simply randomized abiraterone plus or minus radium in these men with mCRPC and bone-predominant disease. And the bad news in this trial is that there was a clear excess in fractures in the experimental arm when the trial was analyzed. So please don't combine abiraterone and radium-223 in your practice. So the trial was stopped, and this combo was considered, not to be used. Right at the same time, there was another trial asking the same question, but this time with enzalutamide. And this was in Europe, developed by, supported and sponsored by the EORTC. So at this time, the chairs of the trial probably faced two options: either stopping the accrual in their trial, just trying to avoid what happened in AR-223, or amend their protocol to make burn-protecting agent, mostly denosumab, mandatory in this trial, because Matthew and colleagues could show that in AR-223, the burn-protecting agents were mostly protective against the fracture in their trial. So actually, this second decision was made, which was courageous, obviously, and of course, an IDMC was reviewing data every 2 days to make sure that there was no excess in fracture. They first reported data about fractures before and after this amendment. And I think this data is truly important for our practice. The two upper curves are the curves before the amendment, and enzalutamide plus radium was associated with approximately 50% fracture rate, 50%, 1 out of 2, by 2 years' time. So quite terrible. Even enzalutamide alone, 25% incidence of fracture by 2 years' time. Then please pay attention to the two other curves, red and bluish. Actually, those are the exact same treatments, but with bone-protecting agent protections together with denosumab. It's just flat. You're almost completely preventing the patient from developing fractures. So even before I show you the data for efficacy for this trial, I think this is really, really informative for all the practice. We should use bone-protecting agents in men with CRPC and bone metastasis, probably regardless of which treatments we are using, RPs, chemo, radium, etc., etc. And I think this is a key message. And finally, the good news is that thanks to probably this amendment, not only fractures were scarce in PEACE 3, but the trial is positive, and indeed this time, overall survival is significantly improved in the experimental arm with the combination of enzalutamide and radium. The data were just published today or yesterday, so just have a look. You'll learn more. The paper is in Annals of Oncology. You'll learn also more about radium at this Congress. We will have more data from PEACE 3 for PSA and alkaline phosphatase changes. Also, the REASSURE large experience will be reported. And finally, the phase 2 CAMRAD trial will be reported Tuesday morning at the oral session by Dr. McKay. We are waiting for 2 other trials, phase 3 trials, with radium-223. RADIANT is soon to deliver, and this is a trial addressing whether radium-223 still has a role in patients who have exhausted an AR pathway inhibitor, because we don't really know. Radium-223 was developed before the eve of abiraterone and enzalutamide, so we don't really know what the efficacy is for this agent post-RP, and even more probably, or as important, post-RP and post-docetaxel. So we will know thanks to this trial, and hopefully we will see data very soon, maybe before the end of the year. DORA is looking at the combination of docetaxel plus radium. We know that it's doable to combine for a long time, actually, and we will have randomized data. So coming back to all the patients, remember triplet therapy for mCRPC and then progression after about a year and a half, both biologically, clinically, and by imaging. So what would you do? Would you think about radium by this time, understanding that he has bone-predominant disease? Would you prefer going for a taxane again with cabazitaxel? Would you, I guess, test? Maybe we can keep the testing for later on and say that the test is not available or just negative. Would you use lutetium PSMA? What would be your discussion with the patients? Maybe Elena first.
Well, the patient is a candidate for radium, that is for sure. Alone or in combination, that is the question for a patient who has already progressed on an ARP, whether the combo is superior or not to radium immunotherapy. I don't know.
Sure. Matthew.
Yeah, all great questions. So I'll take the easy answer. I would certainly add a bone protective agent for all the reasons, the abundant reasons you described. And I'd want more info. Like here's where we don't have the information in the case, but I want to see the PSMA PET scan. I think of the RLTs as really like the therapeutic index is in part like anatomic, right? Like, so you have to have enough burden of disease to justify giving those agents. Otherwise, most of the radiation dose goes to normal tissues. So I'd want to know like how extensive their disease is, and in the case of PSMA lutetium, I want to know the intensity of uptake and consistency of uptake. So, and as most of you in the audience know, of the, let's say, PSMA lutetium eligible patients based on vision, there is a wide range of heterogeneity of intensity of uptake, maybe 10 to 50-fold differences from just barely eligible to like Christmas tree kind of scans that we get. So I'd want to know that. I certainly would want cancer genetics, and I'd be in an early progressor like this. This is almost like pushing towards like aggressive variant prostate cancer. Unless he had a lot of disease on his scans, I would be more inclined probably to go with chemotherapy.
Even if he has received already the Taxol.
Not the same taxane.
Yeah.
Then I might even be thinking like, I'd want to know I want to see the cancer genetics. His PSA is, if he's got a lot of disease with the PSA 1.2, I would be thinking like carbocabazitaxel maybe. But otherwise, I don't think we have enough information from studies to know whether it should be radium or PSMA lutetium.
So probably 3 messages: testing, and Elena is probably going to tell us more about that. PSMA PET, if you can, bone protecting agent, and then discussion, depending on all these results and the options we just discussed.
And we're glad to be in this place, right? Because if you think of like,
of course,
when we began in this more than 20 years ago, like there wasn't a lot. Like, so now we're talking about different forms of imaging for purpose of treatment selection,
Agreed.
the role of cancer tumor genetics. Like, there's a lot to consider, right? So, the field has really advanced a lot in that time.
All right, let me skip this for, maybe just rapidly. We have sequential data with docetaxel and radium, and actually it suggests that using radium first and docetaxel second might be better. But of course, we need to be cautious. This is rather small, 70 patients only. For the sake of time, I'll ask Dr. Castro to now speak about biomarkers and mCRPC. Elena, please.
So I think perhaps one of the biggest changes that we've seen in mCRPC in the last 5 years has been the use of biomarkers to select therapy for our patients, no without some controversies and no still with some unknowns that we need to address. So we have different type of biomarkers to select therapy. We have genomic biomarkers that we identify by sequencing the DNA from the tumor to identify if a patient has an HRR alteration or a BRCA mutation. And we also have imaging biomarkers now to identify PSMA expression. And different trials have been conducted with these biomarkers. Vision 3 was the first phase 3 trial with the radioligand lutetium PSMA, and the study demonstrated the benefit of using lutetium PSMA for the treatment of patients with disease progression after RP and chemotherapy. And there was a clear benefit in RPFS, but also a benefit in overall survival. To be eligible for these trials, patients had to have at least one PSMA positive lesion, and the expression had to be, the SUV had to be higher than in the liver. And I think we have had multiple discussions, and Matthew referred to that earlier, about how much this expression, how high the expression should have to be, which is the best way to measure that expression. Can we just measure the mean, or how do we measure actually the PSMA expression? But with the biomarker that was used in the trial, the study was positive, and that led to the FDA approval in March 2022. And using the same biomarker, the PSMA4 addressed the benefit of lutetium PSMA for patients who have progressed to an ARP but were naive for chemotherapy. Patients have to be eligible for an ARP switch because the control arm was a second hormonal agent. And in this context, the study demonstrated a very clear rPFS benefit. One thing that the trial allowed was for patients with radiographic progression in the control arm to cross over to receive lutetium after, as I said, a radiographic progression, and more than half of patients actually receive lutetium, and probably that has difficulted us to see a clear benefit in overall survival, because at the end, most of patients in the control arm also receive the experimental treatment. With those results, there was a benefit in other secondary endpoints in the study: objective response rate, PSA response rate, time to a second treatment. And with all those data, the FDA approved the indication of this indication of lutetium PSMA very recently, a couple of months ago. But the radioligands are here to stay, and lutetium comes with other radioligands as well, targeting PSMA, but also with other formats. Actinium is an alpha emitter, which is also very promising, and there are multiple trials investigating these and also other radioligands, radioconjugates, and etc. So we are going to be learning about all these new molecules and this new mechanism of action to treat prostate cancer in the next years. And we've been talking already about PARP inhibitors, and for many years we have had PARP inhibitors to treat other tumor types. PARP inhibitors in monotherapy demonstrated in 2020 the benefit for the treatment of mCRPC patients with BRCA and HRR alterations, and multiple trials have addressed different combinations with the aim of improving the responses of patients with BRCA and HRR defects, but also to expand the benefit of these agents to patients without these defects. The rationale for the combinations are multiple, and the ones that have demonstrated a greater benefit so far are the combination of ARPs and PARP inhibitors. There is a crosstalk between the androgen receptor pathway and the DNA repair pathway, the HRR pathway, and some preclinical data show that by combining AR inhibitors and silencing or inhibiting the activity of PARP, there could be a synergy. And this synergy was investigated in 3 clinical trials that were conducted at the same time and combined abiraterone with olaparib and niraparib, and enzalutamide with talazoparib. And in these 3 trials, we've seen a clear hierarchical benefit from these combos, and the patients that benefit the most are those with BRCA alterations. Here you can see data from the PROPEL study that investigated olaparib plus abi, and I don't know if you can see it here, but the benefit of adding olaparib to abiraterone in this patient is so clear. It reduced the risk of death by 70%. So I think it was very, very impressive. We have a second study, that is the magnitude study, that in patients with BRCA alterations demonstrated a benefit in rPFS and a trend to improve overall survival. And finally, the TALAPRO-2 study that investigated the addition of talazoparib to enzalutamide in patients with and without HRR defects. Recently reported the overall survival data in the intention to treat population. In this population, there was a benefit in overall survival when patients were analyzed by the presence of HRR defects or not. The most clear benefit was observed in patients with HRR defects. So we have been discussing about who are the patients that benefit the most for the last couple of years, and actually the agencies also have looked at the data probably in different ways, and we have different approvals. So PROPEL, olaparib plus abiraterone in the FDA approved this combination only for patients with BRCA alterations, whilst EMA approved it for all mCRPC patients. Something similar happened with Talapro-2. FDA has restricted the approval for patients with HRR defects, but in Europe it is approved for all patients. And niraparib plus abiraterone is approved by both agencies for patients with BRCA defects. So we've been discussing whether we need to test or not to test our patients, and recently the ASCO guidelines recommend that all patients with metastatic disease should have both tumor testing and germline testing. Tumor testing in order to identify candidates for PARP inhibitors. Remember that in prostate cancer, somatic alterations are more frequent than germline alterations, and the reason why we need to have germline information is not only for therapy purposes, but to inform the individual and the familial risk of prostate cancer, but also other cancer types. What the guidelines say is that in some patients, if a ctDNA analysis has been performed and the results were negative or not informative, it may be worth repeating the analysis once the clinical situation of the patient has changed by ctDNA or preferably in a newly acquired biopsy. For germline, of course, if we identify an alteration, patients should be referred for genetic testing, for counseling, sorry. But the bad news is that despite this recommendation, the number, the proportion of patients that are currently being tested is small. And this is something that we see in US and we see in Europe and we see everywhere. So currently is less than half of patients are being tested. So less than half of our patients are being offered a treatment option. So testing is critical. There's many issues around testing, like we know that about a third of tumor samples fail NGS, and we need to implement protocols in our centers to really improve this. And perhaps this will change if the studies that Karim presented in mHSPC are positive and are likely to be positive because of the benefit at least patients with BRCA and HRR defects get from these drugs. And then we will have to test patients earlier, and how are we going to implement this in our sites? Perhaps it's easier if it's a patient recently diagnosed, the chances of successful testing are greater. So, but PARP inhibitors are great therapies, but also with some side effects that we need to learn how to manage. The most frequent side effects are hematological side effects, anemia, thrombocytopenia, neutropenia. The prevalence of these side effects depends on the agent. We need to monitor carefully. Anemia is the most frequent one, and usually it occurs in the first 3-4 months, and we need to be vigilant. Non-hematological toxicities include nausea, vomiting, there could be some the diarrhea, constipation, and fatigue, particularly in combination. These PARP inhibitors with the ARPs can increase the fatigue. And there are also some other rare side effects, such as myelodysplastic syndromes and pneumonitis or thrombotic events. But we also need to look for those alterations and with the myelodysplastic syndrome, be vigilant that if an anemia or thrombocytopenia is not recovered in 4 or 6 weeks, perhaps we need to refer the patient to the hematologist, because these are obviously very severe side effects. So imagine a new case is a patient that has been treated with triplet therapy, and after 12 months, the PSA starts to go up, and after 20 months of treatment, the PSA has already reached the castration-resistant levels. We do genetic testing, and we identify germline mutation at that time. So a little bit is what we need to discuss with this patient, and what are the treatment options for this patient. What do you think? How to discuss this with the patient?
Yeah, I think this is very timely, because if this gentleman was treated with a triplet and is now progressing with CRPC with a detectable BRCA2 mutation or deletion, I think we will all agree that he should go for a PARP inhibitor, and probably a PARP inhibitor right now. The question is whether this should be done as a single agent or as a combo with another AR pathway inhibitor. I guess it's fair to say that in a scenario when the patient has received prior abiraterone, it's probably tempting to use enzalutamide and talazo as a combo, because we know that enza may have some efficacy post-abiraterone. But if the patient has received darolutamide, which was the case here, we don't really know. We don't really have data. So what would you do typically in your practice? Would you go for a single agent PARP inhibitor? Would you go for combo?
You know, we are in a very terrible situation in Spain, where the only treatment that is currently reimbursed is a combination.
Okay.
It's a combination of talazoparib and enza in this case. So these patients benefit so much from PARP inhibitor. It's the only thing that has demonstrated really to improve outcomes, that I don't mind to give a combo and to repeat the ARP. I don't know whether this is going to do anything or not.
Matthew, I guess you have the options to decide here in the US. So what would be your practice?
We do, but I would give PARP monotherapy.
Mm-hmm.
You know, we just don't know that the ARPI in a post-ARPI setting has additional value. I totally understand the rationale in Spain. That's what you have. But I would give PARP monotherapy.
Right. There's
enthusiastically too, by the way. These are the patients who really benefit, right?
Oh, yes.
Yeah.
Elena, there's a question about timing of testing. When do you request genomic testing, germline and somatic? Should this be done by the urologist initial visit or after oncological referral? So ideally, what would be your recommendation about timing for testing?
So germline testing we can do anytime, and it is recommended for all patients with metastatic disease, because the chances of identifying a germline mutation are quite high, around 10%, depends a little bit. So it can be done anytime. The urologist can request it, yes. The only thing is that the patient needs to have some counseling before the test, just understanding what are we looking for and what could be the implications of the test. But different centers have it organized differently. In some places have to be referred to cancer genetics to request the test. In other places is mainstreaming, and the urologist or the medical oncologist can request it. For the analysis of the tumor, Again, we could do it at any time because what we know is that these BRCA and HRR alterations are early events that already present in the primary tumor. The only thing is that if we request it very early, and we don't, in some cases, we may not know whether the patient was eligible for a PARP inhibitor later on. But I think these things are changing and will change once we have data for mHSPC.
Brief questions, brief answers, so that we can move on. Which or what germline testing do you recommend? Only BRCA2, BRCA1, or more genes?
No, the recommendation and the ASCO recommendation is to test for BRCA1, BRCA2, Lynch syndrome genes, mismatch repair genes, HOSB13, and consider ATM, TEC2, and PALB2.
How do you manage anemia with PARP inhibitors? Do you use IV iron, or do you wait to treat with IV transfusion when it develops?
It depends a little bit on the level of anemia. In some patients, we can stop the drug for a week and then they will recover. In other cases, if it's a grade 3, and then patient needs a blood transfusion.
Right. Okay. Let me, and I'll try to be brief on that, show you what we might expect in terms of newcomers in castration-resistant disease. And actually, indeed, the androgen receptor remains the main driver of a disease. This is actually the key oncogene driver. Even in patients with very advanced disease, the large majority of patients still have VAR as the main engine of a disease. What the beauty is that we start better understanding how the disease can circumvent actually the best hormonal therapy we're using. And for example, mutations appear in approximately 20-25% of these patients, and they actually make other steroids able to stimulate the androgen receptor. Not anymore androgens, but glucocorticoids, estrogens, progesterone, for example, for the most frequent mutations. So if this is true, and I think it is, in these cases, you should envision either new AR inhibitors able to target these mutated AR versions, or actually drugs that prevent the making of these hormones, not only androgens. This is actually what we are currently doing, both strategies. Actually, this is, for example, ODM208, which is now called MK5684, and it's preventing the making of all steroid hormones, so mineralosteroids, glucocorticosteroids, and sexual hormones, both estrogens and androgens. And of course, you need supplementation to make this drug viable. And it actually works. And as this was predicted, it works much better if patients have mutations. You would expect this is for you guys to the left-hand side of this slide. You can see that for patients with mutations, most men derive benefit, really. And those men had very advanced disease. They had exhausted everything. While patients with AR wild type benefits much less. And this is also reflected by duration of efficacy. So eventually we'll see whether this drug goes to the market. Phase 3 trials are currently ongoing, and whether we will need to test and restrict use to patients with AR mutations. Other targets, and I think promising targets. STEAP1, and by the way, we know these targets for probably 25 years, but it's just recently that the pharma industry was able to develop inhibitors, either bispecific, radioligands, ADCs are under development. But for STEAP1, for example, this was a bispecific, which is called xalutamig. I did my best. And it really works very nicely in, again, very advanced disease. Phase 3 trials are starting. Kallikrein-2, for those of you who are not familiar, let's say it's the brother or sister, whatever, of PSA. But as opposed to PSA, which goes mostly into the blood, kallikrein-2 remains into the cell, so it can be a target for treatment. And as you can see, a radioligand using an alpha emitter showed efficacy a year ago, and we will see more data, I think tomorrow night, if I'm not wrong, using a bispecific, which I think is promising. But stay tuned and you'll see the data tomorrow. Targeting kallikrein-2 can be done, as I just said, using a bispecific. So again, for those of you who are not familiar, you are binding to the target, kallikrein-2, but also binding to CD3, and that can be done with other molecule, so that the T cell will come to cancer cells and hopefully will kill them. EZH2 inhibition is also understudied in prostate cancer, and EZH1 may also follow soon. EZH2 is involved in epigenetics. This might be important also, and perhaps even more important, in patients that are hard to treat, those with very undifferentiated cancers and neuroendocrine differentiation. There is efficacy from a randomized phase 2 trial released at ASCO GU this year that combining enzalutamide plus EZH2 inhibition is better than enzalutamide alone after failure of prior abiraterone. And a randomized phase 3 trial is currently recruiting patients to confirm this finding at a larger scale. And there are other phase 3 trials ongoing and other EZH2 and, as I said, EZH1 inhibitors being tested in early phase assessments. So if you have questions, that's the right time to ask us. We still have a little time. I think there are some. Let me see. How is the best way to identify when would be appropriate use of kallikrein-2 targeting agent? Good questions. We are actually learning. The good thing is that kallikrein-2 is very specific to prostate cancer, so it's actually expressed quite early in the course of a disease, and there's mostly no other organs expressing kallikrein-2. So you may envision that if inhibition works, and I believe it does work, we may develop these agents quite early in the course of a disease. But of course, this is too early to say. Any comment from you guys? No? Okay. What else? How quickly should someone be put on androgen deprivation therapy when diagnosed with local high glycine? Okay, localized disease, high-risk localized disease with a high glycine score. Should we go immediately for ADT, I guess, with radiation, or can we wait? Any comment?
There's not a lot of point in waiting, I don't think. Like, you have the information you need. And I'll extend the question like another way. Like, I think that the compelling data for treatment intensification, now going back to metastatic disease, I've really changed my approach to this. Like, it's really not like, let me explain the history of why we intensify therapy. It's like, this is the current recommendation. So when I'm meeting patients with de novo metastatic disease, they start their ADT, I prescribe them their ARPI on the first visit, and I often get, blood-based tumor genetic testing. Like, we need this information, right? And the latter is sometimes used to make the subsequent decision, which is whether you would also add chemotherapy.
Right. Totally have a question. I presume everyone in the P3 trial also continued ADT. Is monthly BPA necessary? So yes and yes. Everybody was on ADT forever, and this is standard of care for CRPC in P3, combining again radium and enzalutamide, and a monthly BPA is needed in castration-resistant disease, which is not the case, by the way, in castration-sensitive disease. Castration-resistant, you need monthly treatment with denosumab. Okay, I hope I was clear. So monthly for castration-resistant disease, yes. Do you currently utilize lutetium PSMA in your clinical setting, and what role do you think it should play in the treatment escalation pathway, given approved indication with PSMA vision and PSMA4 and ongoing trials with PSMA addition in castration-sensitive disease. So when basically is the best time to use lutetium PSMA?
Well, like many other questions, we don't know, right? We don't have sequencing data. There's an OS benefit post-chemotherapy. There's not pre-chemotherapy. That may be for the reasons described, including the high rate of crossover. That said, I'd say PSMA4 does not prove we need to give it before chemotherapy. And so for patients who are good candidates for chemotherapy, I typically give docetaxel first for mCRPC before I give lutetium PSMA, particularly for those who don't have a high burden of PSMA-positive disease. Yeah.
Right. And from a safety standpoint, maybe I may complement this comment. In vision, so in the very advanced setting, we saw quite some marrow toxicity. It's really not zero. In patients with tremendous bone disease, because obviously you are irradiating the entire skeleton in these men when they have, say, 100 bone metastases. So that is something you should pay attention to. And on the other hand, in PSMA4, typically patients with 1, 2, 3, 4 bone metastasis or lymph node disease, the marrow toxicity was lower. So that would be a reason not to wait too long. I agree with Matthew's comment that you may argue one way or another, pre or post docetaxel, but don't wait for your patient, if you can, of course, don't wait for your patient to have 100 bone metastasis, or otherwise be prepared to start transfusion after lutetium PSMA is given. So that I think is a reason for early versus late. And of course, for castration-sensitive disease, we just don't know. We just need to see the readouts, see the benefits, see the toxicity, including long-term toxicity. After radioligand treatment, how often is subsequent chemotherapy problematic due to cytopenias? I can, well, first, mostly no data reported. Personal experience, mostly fine. And that's, but at least with 4 injections of lutetium PSMA, 4 to 6, probably the issues happen when you re-challenge lutetium PSMA, and then again you are exhausting the marrow. But after typically 4 or 6 injection of lutetium PSMA, pre-docetaxel, when we gave docetaxel at progression, docetaxel was mostly well tolerated. We are currently collecting this data in Europe from patients included in PSMA4, in SPLASH, in all the phase 3 trials testing early lutetium PSMA, and trying to figure out what happened when we gave docetaxel from an efficacy standpoint, but obviously also from a safety standpoint. For safety, I think it's fine. Efficacy, we'll see. Hopefully, we will report this data in the coming month or so. But and again, this is really personal experience. There's no data, so all caveats apply. Challenges facing community care providers in taking care of patients with prostate cancer. I don't know if there's no real questions. Just the challenges, but I guess this is more for you guys. We are academics, so you're better placed to address this question. Do you feel AKT inhibition will be helpful for castration-sensitive disease in combination? What do we know from other tumor types with this approach? First question, I'm not going to comment because I think I know the data, so you may figure out. So I don't know if you guys know the data for AKT inhibition in castration-sensitive disease. If not, I can ask you the question, what your opinion is. Do you think the trials will be helpful to patients?
Well, I hope so. The AKT pathway, PTEN loss, is very common in prostate cancer, and so it's a very appealing target. What I don't know is the results of the study, of course, but, and again, we have some issues with how to measure, how to address the presence of the biomarker, but I hope the trials help us.
The other interesting part, we're going to hear other biomarker data, I think, on Monday that talks about P10 loss as a predictor of benefit from docetaxel, at least in mCSPC. So like the question will be this competition of like when you have that finding, should it be AKT inhibition or chemotherapy or both sequentially, I suppose. Yeah,
that's true. Well, tricky question. What is the best control arm in mCRPC trials? RP switch, as shown over and over, not to be efficacious, should agents run head-to-head against chemotherapy?
Well, yeah, I mean, I have found it surprising that the FDA has allowed, as long as it did, the losing arm of previous trials to be the control group for the next trial. Like, you know, progress would usually require that you have the winning arm of the previous trial, but it didn't work like that. I think the answer is a hybrid right now. I think the fashionable control arm is physician choice, either ARPI switch or chemotherapy, and I think one of the mevrometostat studies will use that. I think that's a reasonable thing, provided they're adequately powered, because certainly what I and other academic investigators are going to want to see is how the treatment arm compares not just to the control arm, but to the subcomponents of the control arm, including docetaxel.
All right. I think we're right on time. Any final comments, Elena or Matthew? Or any final questions from you guys? Okay. So let me repeat the question so that everybody can hear it. I guess this was about PSMA PET. Do we see false positive? Answer is yes. There are some false positive, and this is true for any imaging. If you see just a rib spot, be careful. It can really be a false positive. I'd like to thank you very much for attending and for your questions, multiple questions, an interesting one. And I'd like to thank Matthew and Elena for their presentation. Thank you very much.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, ZERO Prostate Cancer. This activity is supported by independent medical education grants from AstraZeneca, Bayer HealthCare Pharmaceuticals Inc, and Johnson & Johnson. To access all materials for this activity, visit peerview.com/TRR860.